So we're going to go through some of the points about diabetes. I'm going to go slightly beyond what you need to know. By doing that, I will try to point out what you need to know. I will give you more explanation to what you should have already learned elsewhere. So hopefully, will help you to learn the content easily. Let's look at the diabetic complications of the eye. Diabetes can affect every single structure. It could affect the eyeball or structures outside the eyeballs. Of course, you should be aware of diabetic retinopathy and maculopathy, and they are all related to the vessel problems, the neovascularizations and leakage. Retinopathy could be non-proliferative or proliferative, which could lead to all sorts of complications. Macula could become edematous or ischemic. For the cornea, it can lead to dry eye disease because of autonomic neuropathy. The loss of corneal sensation can also lead to cornea abrasion, which can be complicated by infection and cornea ulcer. For the iris and trabecular meshwork, neovascularization can occur, leads to rubeolous iritis. As the name implied, it means a red and inflamed iris. They could block the aqueous drainage system, lead to elevated intraocular pressure and neovascular glaucoma, and it's very difficult to treat. Patient may also develop Argyll-Robertson pupils, which is rare. Even without neovascularization, diabetic patients have a higher risk of developing primary open-angle glaucoma and normal tension glaucoma. When affecting the lens, it could lead to fluctuation of the refractive error, classically described as a transient hyperopic shift, meaning long-sightedness. This is associated with a rapid change of hyperglycemic status, and that reduces the refractive index of the lens. Also, cataracts, of course. The increase in glucose level leads to sorbitol accumulation in the lens. As you might remember from your biochemistry, it's another pathway that branches from the glycolysis pathway. That increases an osmotic effect, and water moves into the lens cell, causing lens rupture and lens opacification. It can also affect the optic nerve, known as DM papillitis. It is a relatively benign condition. However, an important differential diagnosis is non-arteritic or arteritic anterior ischemic optic neuropathy, known as the giant cell arteritis, which you will learn in ophthalmology clerkship. As I said, it can also affect structures outside the eyeballs. The cranial nerve leads to cranial nerve palsy and diplopia. It can affect the eyelid and the orbit. Now, if the infection, the cellulitis, is superficial, then it should be safe. However, they may infiltrate the deeper part and affect the orbit, leading to orbital cellulitis and even orbital abscess. Rhino-orbital mucormycosis is a fungal infection of the lacrimal system. It's rare, but it's fatal. Just try to get across some basic concept. The central part here is the macula. So that's the retinal region surrounded by the optic disc and the vessel arcade. It is responsible for the central vision. When we say retina, we refer to the peripheral part. So you may hear terms like panretinal photocoagulation. That means applying laser to the whole retina. For the back of the eye, it could either be retinopathy or maculopathy. For retinopathy, it could be non-proliferative or proliferative, depends on whether there is new vessels or not. Now, for non-proliferative, it could be mild, moderate, or severe. For proliferative, the neovessels could occur on the disc. That's the neovascularization of the disc, NVD. It could occur in some other places, known as NVE. The term is neovascularization elsewhere. If it occurs on the iris, it's known as neovascularization on the iris, NVI. Now, the neovessels could bleed into the vitreous, and that's vitreous hemorrhage, VH. So the patient will see floaters and the vision will drop dramatically because the blood actually blocked the vision. Now, if the neovessel fibrose, it could pull onto the retina and cause tractional retinal detachment, the TRD. Now, mild to moderate non-proliferative diabetic retinopathy per se will not cause any symptoms. However, if the patient also have other complications, for example, maculopathy or cataract, they may have blurred vision. As you can see, the fovea is right at the center of the macula. So when the macula is affected, because it is responsible for the central part of the vision, maculopathy could lead to blurred central vision, metamorphopsia, meaning that the straight line becomes curly, and micropsia, meaning that the objects look smaller. Now, these are symptoms of macular edema. The edema could be focal or diffuse. There could also be ischemia. Now, there are also other terms with specific definition, but probably not important for your practical purpose. What you need to know is that maculopathy could occur even if the patient only have mild retinopathy. It could be difficult to detect with fundus photograph or fundus camera or direct ophthalmoscope because you don't have the stereopsis to appreciate the thickness of the macula. Say, for example, in case of macular swelling, it could be very difficult for you to detect. Now, you may be able to see some hints, such as hard exudate and dot hemorrhage, meaning that there are leakage in the macula, but it is very challenging to actually appreciate a proper macular edema. To understand why the pathologies look like what they look like, we have to go back to the basic science. This is a diagram I borrowed from a histology textbook. The retina consists of 10 layers. Now, the deeper layer are the plexiform and nuclear layer and the photoreceptor layers. They are packed with cells. The more superficial layer is the retinal nerve fiber layer. The nerve fibers come from the optic nerve. If you like, the nerve fibers cover up the whole superficial layer of the retina like a carpet. Outside is the vitreous body. So bleeding into the region could either be trapped in between the retina or vitreous, which is a preretinal hemorrhage, or the bleeding could go inside the vitreous, hence vitreous hemorrhage. Both conditions can block the light from reaching the photoreceptor layer. So what happens is this. When you have leakage, and that applies to hypertensive and diabetic retinopathy, you have blood and exudate. When the exudate or blood is trapped extracellularly in the deeper layer, they tend to be small with a discrete border. And so this is why they have this same shape. And because of the content, hard exudate looks like more yellowish and bright in color. Microaneurysm may occur along the vessels and eventually rupture, lead to dot blot hemorrhages. It can also leak and causes a hard exudate. Now, blot hemorrhage arrive from the venous end of the capillaries. And again, the surrounding is fairly restricted in space and hence the shape of the blot hemorrhage. Now, for flame-shaped hemorrhage is more superficial. It is bleeding in the retinal fiber layer, and that's explained the flame shape because it is like a sort of impingement image of the nerve fibers. Cottonwool spot looks bigger, whitish, fluffy, and looks like it blocks everything underneath because it is a nerve fiber infarct, and that occurs at the superficial layer. Diabetes can also lead to cystoid macular edema. It could happen in the macular region and is not specific to diabetes alone, and it's difficult to see with a direct ophthalmoscope. Basically, again, the edema looks like several cysts grouped together, and the shape is all about anatomy. So what we call the petaloid pattern is like a flower shape. These photos shows the dot plot, flame-shaped hemorrhage, hard exudate, and cottonwool spot looks like. I'm also showing you the distribution on the nerve fiber layer, so you can imagine why flame-shaped hemorrhage has that shape. So why do we have diabetic retinopathy and maculopathy? Basically, it's all about occlusion and leakage. That leads to ischemia and vascular proliferation. For non-proliferative retinopathy, hyperglycemia leads to formation of advanced glycation end product and damage to retinal capillaries that compromise the capillary walls and leads to microaneurysm formation. The microaneurysm can cause hemorrhage, leakage, occlusion, activate leukocyte adherence to the capillary wall, and therefore leads to hemorrhage, hard exudate as a result of leakage, and cottonwool spots as a result of nerve fiber infarct. Proliferative retinopathy is due to ischemic condition, which stimulates the formation of vascular endothelial growth factor, the VEGF, causing neovascularization. Macular edema is the result of leakage, chronic inflammation, and endothelial damage and causes visual loss. This is the ETDRS classification. You don't need to remember this. I personally don't remember it. Just want to illustrate a few things. First of all, there are different stages of non-proliferative retinopathy. The mild one looks fairly normal. The moderate ones look obvious with diabetic retinopathy, but also may have some cottonwool spots. Severe one has more extensive hemorrhage and exudate and cottonwool spots. Now, secondly, The follow-up scheme changes according to the severity of the disease, and you should consider referring to ophthalmologists in severe cases or worse. Now, even if the patient have moderate cases, if the diabetic control is poor, you should also consider referral. Treatments include panretinal photocoagulation, what we call PRP. Now, the whole point is to sacrifice some of the less useful peripheral retina to reduce the ischemic condition because now there's less oxygen demand, and that preserves the central vision. This suppresses the neovascularization as well. Focal and grid laser is a type of light laser and is used for treating macular edema. Intravitreal injection of anti-VEGF, the anti-vascular endothelial growth factor, can suppress neovascularization and resolve macular edema. Also, we treat complications as well, including glaucoma, vitreous hemorrhage, and also tractional retinal detachment. These are the risk factors that could worsen diabetic retinopathy. Again, you don't need to recite them. They all make sense, and once you understand them, you remember them. Obviously, a long duration of diabetes and poor control can worsen the retinopathy. Pregnancy could lead to hyperglycemia and poor diabetic control. Hypertension obviously causes further damage to the vessels and so worsen the retinopathy. Also, nephropathy. Now, the presence of nephropathy already implies that the vessels in the body are affected by diabetes, and so as the eye. Hyperlipidemia, smoking, obesity, anemia. Now, they affect the vessels, worsen the ischemic condition, worsen the hypertension, and so these risk factors are obvious too. Cataract surgery can lead to ocular inflammation, and therefore often we see worsening of the retinopathy or maculopathy after cataract surgery. These are pictures showing you what NVD and NVE looks like. You can see that they are like tiny vessels that branch off irregularly from the main vessels. When there is fibrosis, that could pull onto the retina, causing tractional retinal detachment. The take-home messages are: remember the diabetic complications, remember the signs of diabetic retinopathy, which are totally examinable. There is no ophthalmic treatment for mild to moderate retinopathy, and so when you're referring the patient to us, it's mainly because of something that can be treated by ophthalmologists, or if you're worried about diabetic retinopathy that may develop soon, you want us to look after the patients and treat the patient promptly when that occurs. Now, diabetic maculopathy is treatable but quite difficult to pick up. Basically, if there's an obvious progressive blur vision, examine your patient properly, do a proper visual acuity examination, and if the visual acuity reduced, you should refer the patient to us. These are the references. And this is it. Thank you very much.